Good evening, everybody. It's an honor for me to be here straight from Montreal, Canada, with this esteemed panel of colleagues and friends of mine. So to segue a bit into Sanjog's talk, I'm going to present to you a nice case of a retrograde complication. And just before jumping into that, this is my disclosure slide. So we know that when doing CTO PCI, or matter of fact, any kind of PCI, you could deal with multiple types of complications, whether it is cardiac or non-cardiac. In this presentation, I will focus on one of the complications that we see, unfortunately, often, is perforations. You could have main vessel, distal vessel, collateral perforations. Here we will have a case of an epicardial collateral perforation and how to manage that. You're all familiar with this beautiful slide from Manos Brilakis' book, about the perforation algorithm. As you all know, the first step is to inflate a balloon to occlude the vessel, manage the hemodynamic, have a pericardiocentesis kit at the ready, and notify the surgeons. Most often, these measures work very well. Unfortunately, when they don't work, you have to know what to do. One of the things is how to manage embolization with fat coils or other devices, and how also to use covered stents. So I gave a talk at TCT about the complication cart. This is what I have in mind. So you should have at least some of these tools in your lab if you're dealing with chip or complex PCI. So this is the case presentation. It's a 69-year-old male with traditional risk factors. He's known with coronary disease, a positive MIBI in an inferolateral territory. He was bypassed in 2000 with a LIMA to his LAD and an SVG to his RCA. He also had stents put in after his bypass. He has an EF of 50% and a positive stress MIBI. His coronary angiogram from 2017 showed an occluded SVG to his RCA, a patent LIMA. His circumflex that was stented was okay. And at that time, there was an attempt by another center to do antegrade wire escalation for the native RCA CTO. Unfortunately, it didn't work, so the patient was referred to our center. So this was a bilateral 8-French long sheet access for the case. So here what we see a long mid-RCA CTO with an ambiguous proximal cap. And we see that the distal cap is actually right at the bifurcation, which is, as you all know, a complexity factor. We also see that the main collateral feeding the CTO is a tortuous epicardial that comes from the left circumflex. So these are the setup shots. Here you really see well that epicardial collateral that looks interesting because it connects directly. But as you all know, especially in post-CABG patient, these collateral could be very dangerous. So before tackling that collateral, we decided to explore some other options and to see if there was some connections from the septals. Unfortunately, there wasn't. And as you can see here, despite the wire seeming to be in the right position, when you do multiple views, orthogonal views, you realize that actually it's floating in the middle of nowhere. So after exploring decently some other options to avoid that epicardial collateral, we ended up with some myocardial stain, which is actually heals pretty well by itself. And we finally decided to actually tackle that epicardial collateral. Here we have a turnpike LP, 150 centimeters, because we're retrograde, with a Shion guide wire, very carefully navigating that collateral, letting the wire do its work, and coordinating the movements of the wire with the systole and diastole. Unfortunately, as not often happens, this epicardial collateral was very fragile. And when we advanced the microcatheter, unfortunately, we had a perforation that you see right there in the middle of the screen. Now, this could be very dramatic for the patient, especially if it's post-CABG, because it could be in the retro AV groove and have focal tamponade, and it could lead to a disastrous outcome. So the first thing you do when you're faced with that is to control yourself, leave the wire in position, advance the microcatheter proximal to the perforation, and apply negative suction. Once that is done, then you have to think about how you will access this collateral from both ends, so from antegrade and retrograde. So in this case, because the native vessel is CTO, we went through the SVG that was occluded, and we wired it, opened it up, and gained access to the distal bed of the RCA in order to get access to that collateral that was perforated. So we put stents in the SVG just to give us access to that distal bed to manage it. Once we got that, we successfully advanced the wire and another turnpike LP retrograde, antegrade this time via the SVG. And once we had access to the collateral, we deployed some pushable coils through a Renegade delivery catheter. Nowadays, we could use some coils that are compatible with the 0.014 microcatheter as a turnpike, for example, or a fine cross. One of the companies that I use is the Axiom neurocoils that are compatible with 0.014. So once we deployed these antegrade coils, we went back to the retrograde epicardial collateral management, and we have to be very careful there because there's not only one branch that was feeding that collateral, there was also other multiple little branches that I pointed out with the white arrows. So we had to access all these little feeding branches and actually deploy coils there as well to stop the flow to the perforation area. So as you see in the screen here, from the retrograde aspect, we have controlled the flow, we stopped it. Unfortunately, from the antegrade aspect, we still have a leaking that's persisting. So we went back antegrade through the SVG, and we actually decided to inject some thrombin on top of the coils that we already had deployed to really make sure that we stopped all flow to the perforation area. So here's the thrombin injection, 0.2 to 0.3 cc of 1,000 units per cc concentration. You flush it with a bit of saline, 0.1 to 0.2, and the thrombin will do its hemostasis work. So now we have a sealed perforation from both sides, antegrade and retrograde. We controlled all the feeding branches to the perforation, and we managed to avoid disaster. So my take-home complications, and I think Sanjog and Darshan and a lot of us spoke about this topic, retrograde access is useful to be able to complete cases, but unfortunately it's associated with a lot of complications. And as Imad had pointed out, and that Dimitri really taught us to do, is never try to do epicardial collateral unless you're very high volume CTO or chip operator, because these complications could make your patient die. And if you can't manage them properly, and if you don't have all the tools and tricks to deal with them. So always stay calm and composed, have a pericardiocentesis kit at the ready. Try to access your collateral from both ends if possible, when it's possible, and make sure to stop all feeding branches to the collateral. Use your perforation algorithm and use whatever tools you have to make sure that you control that area. So you could use coils, thrombin, covered stents, gel foam, fat, whatever you need to do to stop that perforation, you need to do it. So thank you very much. And I'll leave a bit of time for discussion with my good friends and colleagues.
Thank you, Raja. That was excellent. That was an amazing case and a great save, because once you have this perforation in the AV groove, you can compress the left atrium, and this can be a disaster. And it's very difficult to access surgically, even if you have excellent surgeons. It's a very, very difficult surgery. Can you speak? You described a lot of tools. Can you just, for 30 seconds, make a comment how important it is to know how to use these tools and how to learn to use them before you're actually in a crisis like this? Because the last thing you want to happen to you is in the middle of the night to have to read the brochure about how to use them.
That's an excellent point. And actually, I went through this myself, because when I came back to my lab, we didn't have any coils. They used to call the interventional radiologist to come deliver their coils. So when I ordered the Axiom neurocoils, for example, we had a session with my colleagues where in vitro, outside of patients, we practiced deploying these detachable coils through a microcatheter, either a fine cross or a turnpike. So it's very, very important you practice outside of the patients in order to become very comfortable and for it to become sort of a second nature in case it happens in a case.
One other thing I just wanted to add is that the other place to practice it is in SVG intervention. So if you do a CTO PCI and you use an SVG and then you open up the native, but the SVG is still open, you can go ahead and coil that SVG, and that would be another area to sort of practice that.
Great point.
Or just play with your friends in the interventional radiology suite, where they coil vascular tumors all the time, so that you can get some experience with these devices. The other comment I want to make is when you inject thrombin or beads or other hemostatic particles, you need to make sure that there's not backflash of this material into the main vessel, because you can have catastrophic myocardial infarctions. And then you don't rewire and keep a wire in place, because the outer surface of the wire is going to be covered with this thrombotic material, and you may have catastrophic thrombotic of the entire coronary tree. So after you finish your thrombin or your beads or whatever you do, then you pull everything out. I even take the guide out and re-access without leaving a wire in place.
Great point.
And with that, we're going to go to the last talk. My dear friend Luis Ibarra from Canada. He's done tremendous amount of work under the guidance of Greg Stone and Stefan Renfriend and other experts from all over the world to come up with an ARC CTO document that was recently published in CERC. And he's going to talk to us a little bit about the new language of CTO PCI. So, Luis.
Thank you very much for the introduction. Thanks for having me here. Going ahead with the presentation. So as Dimitri mentioned, this is an overview. This talk will be an overview of the paper that we published earlier this year in circulation, with some of the definitions for studies and trials in the CTO PCI field, the Chronic Total Occlusion Academic Research Consortium. Of course, this was a collective endeavor, so I want to thanks everybody involved. And so the CTO work was divided in 3 different sections: the key anatomic and procedural aspects, efficacy and safety endpoints, and the clinical trial design principles. And we're going to talk a little bit on all of them. So we first need to define what is a CTO. Important here is to understand what is a CTO with typical appearance, so trials can compare apples to apples. I would like to highlight how 2 CTOs divided by island should be measured, from the proximal cap of the proximal CTO to the distal cap of the distal CTO. And here I'm going to show you an example of such a case. We have 2 CTOs in the LAD measuring 6 millimeters and 13 millimeters, and if you combine them, it's going to end up with a CTO of 27 millimeters. We all know that 2 CTOs in the same vessel are usually one of the most difficult scenarios that we can face during a CTO PCI. So it would not be fair to compare 2 CTOs, short CTOs, with a single CTO in studies or registries. Another interesting aspect, and that generated a lot of debate, was the nomenclature for the vessel architecture. One needs to realize that the subintimal space is not really an accurate term for where our equipment is. And because of that, it was decided that we should use a more precise term known as extraplaque or intraplaque. Although the terms true and false lumen can still be used, but for segments before and after the CTO. Lesion crossing strategies were also defined. To mention here, we're not using the term escalation anymore when talking about wiring, either antegrade or retrograde, because as we all know, we tend to escalate, de-escalate, escalate again during during wiring, antegrade or retrograde. So we moved away from the escalation main. It's also based on intention. It's not the real position of the wire. So it's all about, if you want to talk about real position, you need to do the intravascular imaging. And there are several other definitions on CTO devices and equipment, collateral channels, and some other lesion characteristics and complexity scores, and encourage you all to take a look at the manuscript published in the circulation to get more definitions on those aspects. Talking about endpoints, it's interesting here. So we start with the crossing success, and which could be either antegrade, retrograde, or just crossing the collateral. Once you achieve the crossing success, then you're aiming for the technical success, which would be a TIMI flow equal or greater than 2. If we remember the live case, one of the live cases, there was a debate if we had the TIMI 3 flow and whether it's a success or not. So the consensus of the CTO work was that because of the collaterals we have, not always we are able to achieve a TIMI 3. So it would be although we have all the good features of successful intervention, not having a TIMI 3 flow would be unfair to the procedure. This is still need to be proven and in ongoing future studies. Also need to achieve revascularization of all distal branches equal or greater than 2.5. That's a complete technical success. If not all, then it's a partial technical success, and also residual stenosis less than 30%. And to achieve a procedural success, we'd have a technical success in the absence of in-hospital MACE, again, complete or partial, depending on the achievement of revascularization of distal branches. If you're studying devices, then you would choose a specific criteria for a specific device, whether it would be a crossing success for wires, for instance, or technical or procedure if you're assessing drug-eluting balloons or drug-eluting stents. When talking about these endpoints, death, stroke, bleeding, non-procedural MIs, those were really straightforward. But on the other hand, defining procedural MI specifically after the Excel trial wasn't that easy. So we decided to endorse the SKY definition, but also collecting all data so other definitions could be used as secondary endpoints. The procedures presented here are part of the initial therapeutic strategy if performed in scheduled fashion, and should not be considered adverse events. The time limit of which should be well documented in the chart. If a patient comes earlier than planned due to ongoing chest pain, for instance, that is considered an unplanned procedure and therefore a MACE. So just going briefly, we have a pre-index procedure where usually you treat non-CTO lesions, the index procedure, then the second index procedure. You might ask, why not the third? Because at some point we need to stop, otherwise you get a third, a fourth, a fifth. Then post-index procedure, a stage procedure to treat again non-CTO lesions, and we are allowed for optimization procedure to bring back the patient and optimize the final result we got in our intervention. With unplanned repeat revascularization, I'd like to highlight here the CTO-related non-TVR, which is a new classification for which is a new lesion instrumented non-target vessel within a month after the index procedure. And there are several other endpoints. Again, I encourage everybody going to the main paper to take a look at this. Just highlighting the silent stent thrombosis, which is an occlusion that occurs with no clinical sequela, in other words, MI, TBR, or death, and usually is an incidental finding of follow-up angiography. On clinical design principles, which I find the most interesting part of this paper, there's a lot of discussion about inclusion criteria for CTO trials. Of course, it's going to depend on the population and objective of the trial. You have multiple that you could choose on. And so if you're assessing quality of life, if you're assessing MACE, if you're functional, change in ischemia, change in ejection fraction, you're going to choose your inclusion and criteria accordingly. And the same for follow-up. If you're assessing quality of life or functional outcomes, 3 months is okay, but if you're assessing durability or MACE, you'd want a higher, longer follow-up. In conclusion, uniform consensus definitions of cross studies provides greater consistency, more information and insights into comparative health outcomes, And it's important to say that the CTO work is by its nature dynamic and will doubtless be updated in the future. Once again, thank you very much for the kind intention and for having me here.
Thank you, Dr. Dimitri.
Yes, thank you very much, Luis. I think this is a great piece of scientific work, and obviously it will help us have a common language across the globe and further refine trials and endpoints, and that's certainly going to move the field forward. Srinivas, I'd like to thank you so much. It's been a great honor and a pleasure.
No, we have been trying to do that. I request you to wait for 1 minute to do another one important job for us. Actually, in the end, in the concluding thing, generally, Dr. Sushil or Ajay would also join. Sushil was supposed to come, but he's stuck in cath lab, I was told. So as good things all come into end, we kept the CTO session because a lot of interest for doctors. That's how we kept this at the end and started with VAL sessions. Thank you, Dr. Dimitri, for sparing your valuable time and designing the program and organizing all this for us. And a lot of interest, and about 1,000 plus doctors logged in your session, and the other 1,000, we also 900 or so were there in other hall, which we are doing nuclear cardiology and some interesting talks from Dr. Seres and Professor Ansreiber. So after at the end of it, what we normally do is to encourage people to continuously stay in halls. Before in HICC, when we used to conduct, we used to have a barcoding system. So whoever stayed maximum in the hall, we used to give. Then last year, we started giving whoever has logged in for longer, though maybe sometimes you could log in and do some work, that's a different story. But our computer can only analyze when you have come in, when you have gone. So when we see who is the doctors out of 5,000 registrations we had because of COVID, or maybe most of it were free, only 900 plus were prime registrations. At any point of time, we were having somewhere in between 2,500 to 3,000 doctors, something like that, split in 3 arenas. And we are very happy. I also I don't want to be biased. So I made my AV team to get the names up, and I requested Dimitri to read those names which come as a slide. So can you project that slide? Who is the longest people who have logged in for the long? This is a 3-day course, as you understand, started from 3 p.m. to 10 p.m. We also had some enjoyment by some musical drummer of our country called Shivamani. Is a legendary person. So people enjoyed in the late after the imaging session yesterday. Can you project is it done? Can you make it bigger? They're not able to see it. Are you able to see it, Dr. Dimitri?
No.
No? If you share the screen, they will be able to see it, I think. You have to share the screen.
Sir, I cannot be able to share this screen, sir.
Okay, no problem. I'll read it, sir. Basically, the top 5 doctors who have enrolled maximum, who stayed in for a long time, almost every day, and full times are maybe few minutes difference are from each. Dr. Shabbir Ali is a cardiologist in one of the local hospitals here called OIC Hospital. So Dr. Kundu Rana, Dr. Farooq Jawar, Dr. Vandana Anasaren, and then Dr. Anasuya, all these from outside, I think. I don't know them personally, but Dr. Shabbir happens to be from Hyderabad. And congratulations and thanks for all your interest, Shabbir. And we wanted Professor Ansreiber also to get involved in this. Sir is there? Or did he leave? He's another senior person, quite experienced in QCA and always encouraged us with QA for modality. I think it has become too late. They must have gone. So I would like to just show, this is another iPad which we give, which are presenting to the doctor who has logged in for long. He's there, but somehow we are not able to get him here. We will send it to him. Thank you. And before we close, I request you all to watch this concluding video highlights, please. So this will be about a few minutes. And a lot of interesting things which are done. We try to make some small clips and present to you. Please watch this and enjoy before we close.
Thank you very much.
Thank you, sir. 12th edition of TCT India meeting.
Thank you again for inviting me. Thank you.
Behind me, Hendrik.
It's certainly my pleasure and great honor to open this conference.
Welcome meeting. I hope my
pushing the guiding back.
A very good evening and namaskar. TCT India, South Asia.
Severe hypokinesis.
Yes, slide. The dystrophy, how you can make out?
If you have a device that is being perfused from the arch and the graft, it is
if you go probably system dota or excimer laser.
6
Germany and one from London. And then we had 20 odd cases. Dr. Ajit Mullasari also showed, he's here, showed interesting cases. A lot of very good cases were presented across, be it be valves or be it be imaging sessions, and some of the complex stuff which is shown also is quite appreciable. And the role of imaging is highlighted very much in doing the PCI techniques. And we in India now in the phase of structural heart therapy rising also, TAVR got already established. And now we are about to get into more comfort of mitra clip procedure. And that such of cases also were first demonstrated by Dr. Sai from Apollo Chennai. And we had excellent demonstration of that by Raj Makka. So I think that is the thing which we have to learn and adapt more for patient care. And one word of advice which I asked Marty Leon for youngsters to do, I asked him where is the scope for youngsters to learn more. He mentioned specifically he's looking for more therapies for heart failure. And we have to still do good work on it. And the happiest moment he mentioned in his life till now was where TAVR has proved supremacy and established itself. I think Greg Stone also highlighted us yesterday how to conduct proper group clinical research and how even the negative trials influenced him. And he said the mitra clip procedure which helped in heart failure patients, he liked it the most. I think a lot of new therapies have come up in CTO space. And we were thrilled when Dr. Dimitri watched with us, had shown some cases. Dr. Sanjog and all the faculty, be it Ajay, Sushil, and all other US faculty, and all the local faculty, always the great help. The great strength of the meeting, why 5,000 plus registrations happen and everybody comes together is not seeing me. I'm a small man compared to so many big people in the country, but basically the strength of academic program and the faculty, how it comes. That's how I thank each and every faculty. And some of the US faculty, I have to thank them enough. I don't know how to do it because they were not sleeping. Saurav Gupta, actually, I didn't realize the time change in other side of US. He got up and he was just all through there. So like that, Dr. Sanjog had to do some other work. Dr. Dimitri spared his all his time. So much efforts have taken by Ajay and Sushil and Greg Stone and Martili, and all that is a great support. And without all this, I think you have seen the last slide of our academic partners, what we call. Can you project that slide? Without, we can organize a program, we can get you good faculty, but obviously nothing with this COVID gave challenges. We tried to make various hubs across the country. PVRs on the big screens is a welcome change, I feel, where people need not travel and enjoy all these live cases on a bigger screens. All this would cost lots of money. Apart from it, you have a very good AV team. They don't come without things. So, but not only the finances, financial support, and the major sponsors, obviously, I would appreciate Abbott, which has a leading stent maker in the country, and Medtronic also helped, and the pharma Lupin as I think a major contributor. Apart from it, we had all the regular pharma companies like Reddy Laboratories and many others like who helped in the program. Why I call them as academic partners is not only the financial support, but they get support from all the colleagues, coordinate for the live cases. Without that coordination efforts, it becomes very difficult. And all of us are busy. That's why I thank all the companies and all the company people. I think I immediately remember Subodh and Anil of Abbott, and then probably people from Medtronic also worked with Chandra and Nisha. And then we have Coronary Shiva and then Vipin. And to keep on telling names, it's difficult because already late. But what I do generally is I take at least 2-3 good people and try give the responsibilities to them, because obviously if it comes with a few lakhs burden, others will kid on us. So we'll give the responsibility. The AV things were taken care by Lupin, and the transmission thing is taken care by one company, other things like that. So then anything else which was coming, I thought this idea, each hub I handed over to one of few of the pharma colleagues, and though its response was not that great, but it is a beginning. Each of the hub had about 40-50. I think maximum response was in. I didn't want to push in too many doctors also in each hub. We wanted to have all the COVID precautions. That's how all the places had about 40-50 doctors only who came. And I appreciate all the patient logins and all the doctors who participated in this program. I think with this few words, if Dr. Ajit sir, you want to say any final concluding words, or we'll play Janagana Mana later.
Thank you, Srinivas, for an absolutely wonderful conference. And during this COVID times, you really took on this job of putting this together. It's quite a challenge. And I really, whatever I could do and whatever I could attend, I really enjoyed this meeting. Thank you so much for bringing this meeting to us.
Thank you, sir. Dr. Dimitri, you conducted this, and Sanjog, I see them. If you want to say anything, one few words. I don't know, this platform is not allowing it. Yeah.
Amazing meeting. Great honor and pleasure to have us. Hopefully we can meet together next year. Thank you for having us. Congratulations.
Thank you, sir.
Echo all of those comments as well. I, as you know, really enjoy and relish the opportunity to meet with all of my friends and colleagues in India, and I hope that next year we can do so in person again. Congratulations.
Thank you. Hope so. Thank you, Sanjog. Can we all respect our national anthem, and then we close the meeting? Can you play Janagana Mana? Those from South Asian countries.
Janagana Mana Adhinayak Jaya He Bharat Bhagya Vidhata Punjab Sindh Gujarat Maratha Dravida Utkala Vanga Vindhya Himachal Yamuna Ganga Uchala Jaladhi Taranga तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Thank you. Namaste.